to our third PBC Facebook Live event of 2021. My name is Gail Wright, and I am the president of the Canadian PBC Society, a support group for PBC patients and their families. Our group is a registered charity completely run by volunteers, many of whom, like me, have PBC. I would like to thank all of you who have made donations that support all of our programs through the year, and I would like to recognize our series sponsors, Intercept Pharmaceutical and CymaBay Therapeutics. Tonight's guest presenter is Dr. Alan Bonder, speaking on PBC risk assessment, treatment, and prognosis. To get things started, I'd like to turn things over to our moderator for this evening, Dr. Aliya Gulamhusein, Assistant Professor of Medicine at the University of Toronto and a hepatologist at the Toronto Centre for Liver Disease. Welcome, Dr. Aliya.
Hi, Gail. Thank you for that. And thank you for everyone for joining this evening. It's my distinct pleasure and honor to introduce to you Dr. Alan Bonder. He is an assistant professor of medicine at the Harvard Medical School and the medical director of liver transplantation. Dr. Bonder did his internal medicine and gastroenterology training at the Tufts Medical Center, and then went on to do an advanced hepatology fellowship at the Harvard Beth Israel Deaconess Medical Center. His current clinical research is focused in two main areas of liver disease. The first one is that of autoimmune liver disease, where he developed the first autoimmune liver clinic at the medical center and started an autoimmune registry there. And the second interest is that of understanding disparities in transplant and transplant outcomes, particularly as it relates to ethnic minorities, including the Hispanic population. Today, he is going to talk to us about risk in PBC, and we look forward to a great talk and a lively discussion thereafter. Dr. Bonder.
Thanks, Aliya, and thanks, Gail. I mean, it's a pleasure to be here. I'm humbled to be invited to my neighborhood, neighbor up in the north. And again, I'm happy to join and try to help as much as I can. So let me try to share my screen so you can see. And please let me know if you can see it. All right, so when they asked me to talk about risk stratification and second-line therapies, I was actually talking to my research fellow the other day. I hope John is actually in live on Facebook. And he actually showed me this picture. And he said, you know, Alan, this picture reminds me of PBC patients. And I said, really, John, why? It's like, you know what, in one side, you have this growth in the left side, but 60, 70% of those patients will respond to URSO, will do well. And you really don't see them. They pass them on and there's nothing else to do for them. You put them on kind of stand control. You see them, twice a year, you put them on URSO dial and they really do pretty well. I think on the right side is where we have all those climbs and goes ups and downs. And I would say this is a 30 or 40% of the patients where we actually have issues about how to treat them or how to get them under control. I think as Aliya knows, and not everyone with PBC, 30 to 40% of the people do not respond to standard second-line therapy. This is how we start stratifying. What are those patients' characteristics? What are those patients' demographics that we need to look into as the first encounter and the future encounter, so we can try to get them treated and got to get them under biochemical remission. So this is a picture of me. Again, the first thing I need to do is for Harvard, I have no conflict of interest to disclose. And the first thing that comes out to my mind is when we have patients with PBC, we diagnose them with PBC. We know the standard of therapy is starting on ursodiol 13 to 15 milligrams per kilogram. And the things that we are looking now, I think, is how are we going to stratify those patients? I think if you look at here these patients, we need to kind of look at the demographics. Are they female, are they male? Their age at presentation, are they young, younger at the age of diagnosis before 30s, 40s, 50s, 60s? What are their alkaline phosphatase? What are their bilirubin at presentation? And based on that, we can really over time stratify them and someone who really will respond to ursodiol or someone who we really need a second-line therapy. So what are the two main points that we see in patients when they're coming to see us? And again, this is just all data from Hirschfield in Toronto. And again, you can see that the alkaline phosphatase has been, for the last 20 to 30 years, the main indicator of how PBCs are responding to treatment. In this study, as you can see, there's two groups, and the A group is patients who had an alkaline phosphatase less than 2 times the upper limit of normal, had a pretty good life expectancy, if you want to say the 5 to 10 years, actually even as same as matched controls. But as you actually progress and your alkaline phosphatase starts going up and doesn't come down, this is when we start getting in trouble. So your life expectancy at 5 to 10 years becomes an issue. And this is when patients need to be evaluated or maybe listed for liver transplantation. And the other marker that we have available, it is the bilirubin. And the bilirubin is the same as the alkaline phosphatase. I think, Dr. Kaplan, who was my teacher for PBC, always told me that bilirubin is when the ball starts rolling and the bilirubin starts going up, there is no way to stop that ball coming down. So here you can say in the right side of the graph is a bilirubin more, which is normal, that stays normal over time, actually has a pretty good life expectancy. Again, same as matched controls. And you can see the difference when you actually have an abnormal bilirubin. Again, I think usually the data shows a bilirubin more than 2. You can see how the mortality starts affecting those patients. And again, these patients will need to be referred to a liver transplant center so they can start a transplant work. So how do we define biochemical response, and how do we do that to predict clinical outcomes? So most of us in the autoimmune liver world, we will decide to start Osodai at least for a year. So we will do the 1350 milligrams per kilogram, and we'll do a serial blood test again, but most of us will do 3, 4 the first times in the first year, and we'll define biochemical response, and we can get that alkaline phosphatase close to normal or less than 1.67, and we classify them, and then you're a responder and a non-responder patient. So here's a little bit about demographics and response to treatment. In this study published almost 8 years ago, they looked at females and males in response to treatment. And again, I'm going to go a little bit to the graph. So this is a proportion of patients who respond to therapy. And this is the age of presentation. So I'm going to ask you guys to pay attention to the male graph. And then you can see the male graph. It doesn't matter the proportion of patients who are diagnosed at age 30 compared to at age 60. So it's a pretty kind of stable graph, which tells me that males are actually less likely to respond to ursodiol. If you look at the female graph, you can see that females who are diagnosed earlier in their disease have a less likely to respond to urso. But as you actually go up in the graph, you actually see that the patients, the older they get diagnosed with PBC, the more likely they will respond to ursodiol. And again, this is the same study, but again, when they put them all together, they look at gender. So this is male and females in this graph, and they looked at response rate just by age. And as you can see in this graph, when you approach to the graph, it means that you're more likely to respond. And if you can see this, so if you're diagnosed, even you're a male or female with an age, with an age less than 30, you have a less chance to respond to ursodiol. And as you actually see the graph going down, it actually goes very close to the graph. And you can see there is more responsive to ursodiol. So if we just spaced a little more and we looked a little bit deeper and why those males do not respond to therapy, this is not a study. And then in this study, they looked at male non-responders, again, patients who did not lower the alkaline phosphatase, and they compared to male responders, and they looked at the incidence of liver cancer. And over time, male non-responders had more cancers compared to the male responders. If you compare the female non-responders, female responders, also there's a big difference in the non-responders versus the responders. But when you compare the 4 groups, male non-responders have the higher incidence of liver cancer in this patient population. Another question that we always get asked in the first encounter, does the antibodies mean anything to me? And I can say for most of the time, the mitochondrial antibody does not mean anything. There's no change in prognosis, there's no change in outcomes. There's other 2 antibodies that are present in patients with PBC that might give you a hint that will have other issues in the future. For example, the ANA, specifically the GP210, can lead to hepatic failure and lead to liver transplantation. And the anti-centromer antibody can sometimes lead to worsening portal hypertension. Again, there's all studies about it, but again, this is retrospective data and does not really just give an absolutely true about this diagnosis to patients when they present to us. So how about patients coming in the first encounter and telling me, they have a low fiber scan? What does that mean? So this is a study published by Corpechon, who is the kind of the leading PBC person in France. And he looked at the first fiber scan and looked at the potential of decompensation and survival. And as you can see here, patients who present to us with a low fiber scan is less than 9.6 kilopascals, have a really higher chances of survival. Again, this is compared to a matched control with no PBC. And here over time, you can see as 9.6 that you actually survival will go down, and it's estimated that 7 years, 30% of those people will have some type of liver decompensation that leads into liver transplantation. So recently, I think Aliya was part of this, the Globe PBC got together and we looked at, can we find out what's the best FibroScan indicator that will tell me that you need either a liver transplant or you have some type of event that will lead into liver decompensation. And as you can see here, the hazard ratio is 1, and they looked at almost close to 5,000 patients. And they look at the hazard ratio approach to 1 when the liver stiffness gets close to 10. So the message of this is, again, a FibroScan, which is pretty similar at what he presented before, a FibroScan close to 10, it's pretty indicated that disease has already advanced and that you need further treatments for the future. How about any stages? So liver biopsies are not indicated in PBC, and then it's not part of any other guidelines. But again, this is a study from the New England Journal of Medicine. This is really old, 80s and 90s, and they looked at staging of disease. And again, I think this is pretty expected for any hepatologist. Portal fibrosis is the definition of null fibrosis. Bridging fibrosis is what's called advanced fibrosis, and cirrhosis is the presence of stage 4. And as you can see, the survival of 12 years, of course, it is lower for portal fibrosis. It actually gets worse as you actually get bridging. Of course, will lead into liver decompensation as you get cirrhotic. This is one of my favorite studies. It's almost 15 or 16 years old, but again, this is that ursodiol, the earlier the better. And this is a study again by Corpechon in France, where he looked at the different stages of disease and classified on early. If you look in the left side, stages 1 and 2, and then B, stages 3 and 4. And what he did, he wanted to look if ursodiol made an effect in the long run in the early stage and in a really late stage. And as you can see, in the early stage, patient had improved survival. Almost 90% of the patients were alive at 20 years. You had patients without a liver transplant, so almost 80% of those patients who started an urso early had not had any episodes of decompensation leading into transplantation. They're survived by the Mayo risk score, which is a prognostic indicator. And one of the most important ones, actually almost 91% of them were alive for a matched control with their sex or the gender. Look at the difference when you have a stage 3 and a stage 4. There was really no significant difference when you look at patient survival, patient without a liver transplant, patient with a Mayo risk score, and patient compared to matched control. So the message of this is when we see patients, it's so important to try to get ursodiol with the proper dose, try to get them up there so we can prevent decompensation and decrease survival or the need of liver transplantation. So what else do we have? So we talk about liver markers, liver tests, we talk about FibroScans, and we really have maybe other type of prognostic indicators. So when I look at this is when you have an individual, we actually look at that patient and we try to throw at that patient everything that we have available. So we have liver tests on one side, we have FibroScans on the other side, we have liver biopsy. So we try to kind of stratify that patient to see if that patient will progress or will have any complications from the liver disease. Then we will try to group patients in low risk, moderate risk, and severe risk based on their response to conventional therapy. And with all that together, we can actually try to pull a clinical trial to see what are the high-risk patients that will need second-line therapies or third-line therapies if needed. So what do we have available? I think Aliya works for the Globe, and then we work for the Globe, also the Globe PBC. They came with this very, very important score. And this score is done after a year where they looked at age, they look at the bilirubin, they look at the alkaline phosphatase, the albumin, the platelet count. And what they look like is they can prognosticate the 3, the 5, and the 10-year transplant-free survival. And the other side, we have the UK PBC. I think these two scores are kind of the bread and butter prognostic markers that we can do in patients with PBC. And again, in this UK PBC, you look at the similarities. You have the LFTs, or transaminases, you have the total bilirubin levels, the alkaline phosphatase, the albumin levels, the platelet count. The difference in these two scores is, the UK PBC has a risk of an event at 5, at 10, and at 15 years. So I have a longer periods of survival compared to the GLOBE score. So when we talk about treatments, we have to look at what is a receptor. And again, in the left-hand side here this is before the medication was given. It's a natural substances. That natural substances will bind to the receptor, and that will cause normal cellular activity. What happens when we give an agonist medication? Well, that agonist medication will go into the receptor side and will enhance the cellular activity of that medication. And in PBC, we have two main receptors right now. There are kind of the two main medication groups. In the left side, you have the PPAR agonist, and the right side now you have the FXR agonist. In both medications, their mechanism of actions are you kind of diminish the synthesis of bile acids, you increase the elimination of bile acids, but also decrease the cytotoxic effect of bile acid, which is really one of the main issues that causes biliary injury in patients with PBC. So when we talk about treatments and we talk about second-line therapy, in the US, the only second-line therapy we currently have approved is obeticholic acid. And obeticholic acid is the only FXR that we have available currently. All the PPARs, this is a paper that Aliya published maybe a year ago, and you look at the different PPARs. And again, we will talk about each medication, but I want to mention that elafibranor was just published in Journal of Hepatology, one of the big liver journals, is a PPAR alpha and a PPAR delta. The phase 2 study was really good, and it showed significant decrease in the alkaline phosphatase. Seladelpar, which was PPR delta. Seladelpar was just by Gideon Hirschfeld here in this group, just published a big randomized control trial in our liver meeting, and can show also significant improvement. Saroglitazar is a PPAR alpha and a gamma. I'll show you the data. And then we have bezafibrates and fenofibrates. So this is a POISE trial. This is up to 20. I think this is very exciting for the PBC world. I can say before 2016, we had nothing except urso. And then, we used to use colchicine and methotrexate in when I trained. I think this came up to the market, and then now we have a second-line therapy. And this is a trial that was published in the New England Journal of Medicine. And this is a randomized trial where you look at 3 groups. The total treatment randomization was for 12 months. And as you can see, there was 3 groups. One is at 10 milligrams. One was started at 5 and was titrated up to 10 based on the alkaline phosphatase and symptoms. And the third group was placebo. The second group was if they stay at 5 milligrams, they were dose adjustment in the open label trial for a total of 12 for another year. You look at the improvement in alkaline phosphatase. So the results showed that the main objective of the study was trying to get the alkaline phosphatase below 1.67 of normal. And again, I'm going to show you the 3 results. In the first group, the 5 to 10 optimizing to 10, there was a 46% response, meaning that 46% of those patients were able to achieve an alkaline phosphatase less than 1.67. In the 10 milligram group, there was a 47%, and the placebo was a 10% response rate. And this is very important. I think Aliya just sent a paper or an abstract to the liver meeting. Well, she actually did real world data and confirmed the same kind of data, that this is same as is reproduces in a clinical study. It was able to reproduce in just clinical care. And I think this is a great option for patients. What is a problem for this? I think the main problem is itching, pruritus. I think I can say patients complain about itching and who actually can make their life miserable. So what was the problem? 5 to 10 milligrams caused 56% of those patients to get pruritus. Some of them needed to stop the medication. When you look at the 10 milligrams, up to 70%, versus only 38% of the placebo. So this is a really big issue when we talk about obeticholic acid, but again, something that we need to disclose to patients when they start treatment. So this is the elafibranor study that was just published a few months ago. And this is a study, we were part of this. And we looked at 3 groups, elafibranor 80 milligrams, elafibranor 120 versus placebo. And the objective of the study was to see what's the percentage of the alkaline phosphatase was reduced after 12 weeks of therapy. And the results showed that after 12 weeks of therapy, 120 and 80 milligrams were superior to placebo. When we look at the difference between 120 and 80, we're not significant, even the side effects. But this is also the first study that a PPAR was also improving symptoms such as pruritus. Again, this is a phase 2 trial. It was only 12 weeks, and hopefully we'll get an extended trial, which will come soon. Then we have the Corpechot study, which is in France. So bezafibrate is not available yet in the US. I don't know if it's available in Canada. I think it was just recently purchased by Intercept, so hopefully it will be used soon. And in this study, they looked at patients who wanted to have a biochemical response. And when you talk about biochemical response, it is normal bilirubin, normal alkaline phosphatase, normal AST, ALT, albumin, and PT. And in this study, patients were randomized either to get bezafibrate versus placebo for a total of 24 months, for 2 years. And the interesting part of the study is, as you can see, at the end of the study, 31% of the patients who got bezafibrate had completely normal liver tests. 67% of those patients had normal alkaline phosphatase at the end of the study. But one more extra thing that this study added to the PBC world, this is the first study they look at FibroScan response. So they FibroScan the patients at the beginning of the trial, and they look at the FibroScans at the end of the trial. And then what it showed is that actually the FibroScan, the liver stiffness, improved with bezafibrate, which is really key for the first time we have some data out there about this. How about fenofibrate? So fenofibrate, we have it available in the US. I think we do actually use it off-label here. And this is a study in clinical pharmacology and gastroenterology, where you look at PSC and PBC versus placebo. And again, I'm just showing the PBC data. You can see here, fenofibrate show improvement in ALT, AST, alkaline phosphatase, and total bilirubin. And again, this is an open label, it's not randomized, it's only 20 patients. Again, we can say the data is not significant to show that this medication should be used. But again, because we have no other fibrate in the US to use, this is something really that we can have as our armamentarium to actually treat patients as second-line therapy. Seladelpar is PPAR delta after 3 months showed biochemical response. And this is basically in the study that was presented at the liver meeting last fall. And again, in this study, again, a placebo-controlled trial, and they looked at 10 and 5 milligrams versus placebo. And they look at, I would say, 4 different outcomes. The first endpoint is the proportion of patients who lower the alkaline phosphatase. And as you can see, the 10 was better than 50. The 10 was better than 5, but if you compare that to placebo, it was very significant. The percentage of patients who normalized the alkaline phosphatase was also significant. Up to a quarter of the patients who were treated with seladelpar had a normalization of the alkaline phosphatase. But also, again, we have a new team, there were significant improvements in pruritus and by this NRS score. And finally, ALT would also show some improvement. So I think this is really key. I think, as everyone remembers, seladelpar had to be on hold for a little bit because in the NASH studies caused a little bit of autoimmune hepatitis, but right now it's back on the market, and hopefully we are going to get an extended trial so we can show that the seladelpar actually works as a second-line therapy. Saraglitazar is one of those other medications that was presented. This is a phase 2 trial. This is a 12-week trial. This is a 2 study, so there's 2 types of doses, 4 and 2 milligrams compared with a placebo. The main outcome that they look in the study, they look at the percentage of change in the alkaline phosphatase. And as you can see here, the difference between both doses and the placebo were significant. They did not compare one dose versus the other one. And I think the side effects were not different comparing the medication versus placebo. So it's another medication that we can use as a second-line drug therapy. One more thing that I want to mention to here is there is a study, the bezafibrate. So I think Intercept is right now trying to compound an FXR and a PPAR at the same time. So they're going to try to see in patients who are not responding to obeticholic acid to use bezafibrate, ursodiol, and obeticholic acid. So hitting those patients from an FXR and a PPAR perspective to see they actually have better response. I know they did 11 patients in an Evans in this trial, and they showed that the 11 patients who had the triple therapy actually were able to normalize their liver test completely. So I think that's something that will come in the future and something that we can offer to patients that we cannot hit them with one side of the FXR. We can actually use both sides at the same time. So what is my take-home message? I think in summary, we have to stratify patients who will benefit from second-line therapies. So far in the US, we can only say the obeticholic acid, it is approved. But again, we are using some of the PPARs off label. And again, we do have all the clinical trials in our center. So we do have selaglitazar. So we had this, we had the seladelpar study, and hopefully we have the future studies so we can offer that to patients. And hopefully within the next 2 years, we'll have all those medications approved. And we really have more to offer to those patients who are not responding to therapy. And again, I think it is very exciting. Again, as I told everyone before 2016, there was URSO. I think this is 2021, and we're going to have close to 6 or 7 new medications approved for PBC in the near future. So I'm going to stop there, and I'm going to kind of wait for questions.
Great. Thanks so much, Alan. That was super helpful and very clear. I mean, I think we're all on the same sort of page and sort of moving up, being in this place where URSO was all we had, really. And now the world of PBC has certainly in the last 5 years evolved and changed pretty dramatically. And our focus certainly in the clinic is that of risk stratification, understanding the patient who's sitting in front of you, and then sort of optimizing therapy for them in the best way that we can. Gail, maybe I'll just ask, are questions coming through the chat box here, or how are we identifying them?
Well, as the questions come through, I'll type them into the chat box.
Okay, sounds good.
You can start with the questions that I sent you earlier.
Yeah, so Alan, maybe I'll just ask you, I mean, your approach. I mean, sometimes when patients come to the clinic, they ask us questions about their family members and how to risk stratify or how to assess diagnostically or monitor children, be it daughters, sisters, mothers. What do you usually recommend to an index patient for their relatives?
It's a great question. I think, and this is not a question that we always been asked. I think sometimes we're going to have to make the recommendation. So there's been studies that first-degree relatives, most likely mothers and daughters, are more at risk. So there's a 20% incidence of PBC in the first-degree relatives. So what I would suggest in those patients is to actually check an anti-mitochondrial antibody. I don't recommend doing it before age 18 to 20 because again, I don't want to throw it to the pediatrician. I don't know what they're looking for. So I think once they transition to an adult medicine physician, then I will ask them to get tested. I don't actually ask them to get tested if they're all males. Again, the incidence is actually less than 2%. So again, I don't think it is clinically significant to recommend that. But again, I think that's my recommendation. And if they actually have a positive AMA, again, I do tell those patients that they have the disease and they will have to follow with a hepatologist eventually.
Yeah, I think that makes sense. I guess there's no the data that's there is a little bit, I mean, it's retrospective, there's small series, but for sure we know that AMAs are associated with a risk of disease. It also brings some anxiety though, to know that you have maybe an antibody, but also I think important to know that when patients have a positive AMA and they have normal liver tests, even if they develop PBC, their disease will be mild because we find it and treat it pretty early.
Again, this is what we show. The early we give URSO to those patients, I think the early will really prevent of those patients of getting the compensations.
Yeah, sure. Okay, some questions coming through. So are there any medications being looked at to reverse scarring in PBC or fibrosis?
That's a great question. I think the PBC world is, again, I think there's only the Corpichat study, the bezafibrate. This is the only study they've looked at liver stiffness as a follow-up as a secondary outcome. The answer to that question is no. I think, but when I trained under Marshall Kaplan, he used to biopsy every 3 to 5 years because he was actually concerned about those patients actually progressing pretty fast. And my question to him always is, why are you doing this? And he would say, I don't know who's going to progress. And we didn't have all these tools like, the UK PBC, the Globe PBC scores, the fiber scans. But again, that's a great question. And I think that's something for the future. Most of the studies right now are looking at fiber scans for elastography as an outcome. I don't know if they would include a liver biopsy in the future, but that's something that we can discuss as hepatologists to see if that's something that we need to include for future objective or in clinical studies.
Yeah, sure. I totally agree. I mean, we know that ALP and biochemistries are surrogates of outcome because that's the data we had available. But certainly if we had all the data that we wanted at our fingertips, we'd be able to find lots of different surrogates of outcome. And I totally agree that I think we have to sort of look at the whole patient. Their biochemistries are just one picture, and looking at fibrosis measures over time is important. The same will be true for NASH studies too. They'll look at resolution of NASH or fatty liver or inflammatory components, and stabilization of fibrosis or antifibrotics are the next sort of step. Okay, so what about, as a segue to that, what about PBC with overlapping autoimmune hepatitis or PBC in someone who also has underlying fatty liver? How do you approach or treat those patients?
I think that's a great question. I think we live now in the metabolic syndrome world. And again, I think we're going to have to be prepared that when you have a dual disease patient, so not every, PBC patients can have NASH. Sometimes the only way to know that will be a liver biopsy, unfortunately. So there is no other way to diagnose that. Again, I think if that patient comes to me and the alkaline phosphatase response to treatment with ursodiol and the fiber scan is low, I'm okay not doing anything except maybe asking for lifestyle modifications. But in the future, I see the AST-ALT going up or something and biochemically that doesn't make sense. I think those patients will have to be biopsied to know exactly what's going on with the liver disease. We do encounter them more. Again, all those new medications that we have available are actually getting also tested in the NASH world. So I don't know if this is going to be kind of like a dual therapy thing. But again, I think the answer to that question is, I think we will not have to biopsy all of those patients to find out what's going on.
Yeah, it's tricky for sure. I mean, I think the sponsors and companies will be very interested in marketing agents for both cholestatic disease and fatty liver because of exactly as you mentioned, the intersecting pathways. And that's what we saw with obeticholic acid. I mean, we'll see where that goes. I mean, I think in my practice, I kind of I do exactly as you say. I mean, you definitely encourage lifestyle modification, but I wonder whether we maybe should have a lower threshold to treat in someone with superimposed liver disease, particularly these people that are these patients that might be on the borderline for warranting therapy with obeticholic acid or second line therapy. I tend to sort of think about them individually and say, could this patient benefit in a different way? It's just, sometimes it's the access that's hard, proving to getting funding for the drugs that are hard.
Right. I think in the overlap syndrome, I think, unfortunately, all the PBC clinical trials are excluding overlap syndrome. So there is not enough data to support the use of all the PPARs or FXR agonists currently in patients who have overlap syndrome. What we do in the clinic is we have obeticholic acid, and if they feel that the PBC is the part that's not responding based on our histology, again, for autoimmune liver disease, for autoimmune hepatitis, we do really need a liver biopsy again. Mm-hmm. So if we do find that that's the leading cause of the worsening alkaline phosphatase, then we will offer second-line therapy for that PBC, knowing that that's not going to treat the autoimmune hepatitis. I know Aliya and Gideon have presented data of budesonide in patients with autoimmune and overlap data. Some of those patients with PBC can actually get better. But again, I think this is also a patient population that, based on all the clinical trials, there's not enough data to say or support the use of this second or third line therapies.
Yeah, agree. Okay, so do many patients with high AMA titers and normal liver tests ultimately get diagnosed with PBC?
So there is data about this, and this is data from the 90s and early 2000s. And they looked at 30 patients who had a positive AMA without symptoms, and they followed them without actually starting them in urso. And they actually were biopsying those patients, and after 10 years, 86% of those patients developed PBC symptoms and PBC findings on histology. So the answer is, I don't think the titer matters. I think the positivity tells you that you are at risk for PBC. So those patients do have PBC, and then we would like to treat them as early as we can with URSO.
Yeah, do you treat them before their liver tests rise?
That's a good question. I do. I think URSO is pretty harmless. And I really talk with them saying, listen, your AMA is positive. It could be then 5 to 10 years from now, we will find abnormal liver tests if I don't treat you, or we can treat you and keep your liver test normal. So that's something that I'll discuss with patients. That's actually difference in practices. I don't know if you guys do the same thing, but I would actually disclose that to the patients.
Yeah, I mean, I think everyone has sort of different practices over time. I think those studies that you mentioned are really interesting, right? They're real natural history studies that look at what happens in these people with normal liver tests over time. And there is a high proportion of them developing overt disease. I tend to monitor their liver tests, and as soon as the ALP flicks up, then I have a very low threshold to start therapy. But I think you can argue either way. URSO is so safe, so well tolerated, that the risk benefit sort of lies in the patient's priorities.
Right. I think the only kind of preventive thing, again, will be cost of URSO sometimes. I don't know how it is in Canada. In the US, there's a monopoly in URSO. And of course, the cost of URSO sometimes is pretty expensive. I would say the copays with the help of us will be $70 to $100 per month.
Yeah.
Again, I know that's the biggest barrier to start treatment, but otherwise, I think, as you mentioned, I think your practice is okay. The problem is some of those patients will not return to see us. And again, that's something that maybe you want to catch them and treat them. And that's the way to keep them more engaged in your clinic.
Yeah. For sure. Okay. Any chance of finding a cure?
It depends what we talk about cure. I mean, again, an autoimmune condition will, again, unfortunately, there's no cure. I think there is response. And again, if you have, again, I show you in the graphs that if you have low fiber scans, normal liver test, response to URSO, your life expectancy is same as match control. So I think the definition of that is you'll have to find a different reason to die other than the liver issue, actually to have an issue. So again, I will not talk about response. I will talk about cure. I will talk about more response. Maybe in the, when we do gene modification in the future, that will be something that we can look into, but not now, unfortunately.
That's over our careers and over our lifetimes, hopefully. But yeah, I mean, I think that's true. Like I sort of try to tell patients or sort of counsel them to think about this as chronic disease, right? Like hypertension, dyslipidemia, diabetes. If you're treated, disease can be very well controlled and you don't have to worry about it. But as soon as you stop therapy, or if you don't treat, the uncontrolled element comes in, and then you start to struggle with complications. So I think I totally agree. I think disease control is the target right now. Cure would be ideal, but I think we're a bit far away from that, unfortunately, just yet. Okay. Next one, is there any difference in outlook for those patients with and without symptoms?
That's actually a great question too. So there is two train of thoughts. If you look at, again, this is the early data, 90s and 2000s. They look at patients who presented with symptoms versus patients who did not present with symptoms, and they look at life expectancy. So patients who had symptoms actually had worsening liver disease. This is back, again, late 90s, early 2000s. They look at the data again. I think the Danish people, and they show there was no difference. So you present early with symptoms, if we treat you, because that's actually how you're going to get caught with the disease. I think that would be the best way to caught you, get diagnosed, get treated earlier. I don't think there's any difference in life expectancy. So right now is pruritus, fatigue, any of those symptoms, as long as you get treated, I think, there's not going to be any difference in outcomes.
Okay, let's see. Many patients with PBC have several other autoimmune comorbidities. Does this affect their risk assessment?
The answer is for the PBC, the answer is no. But I think as hepatologists, I think we're kind of the rheumatology of liver disease. So we're going to have to look for something different. So 30% of the people will have Sjogren's syndromes, dry eyes, dry mouth. There's a 15% of people can have rheumatoid arthritis. There's another 6% they have lupus. So once you have an autoimmune disease, and thyroid, you have an increased risk of developing a second or a third autoimmune condition. So it's something that we in clinic, we explore, and we actually try to actually screen for that.
Yeah, agreed. Okay, the next one is, are you seeing more transplants in your practice? And sort of what's your approach to advanced disease in general?
I would say we are seeing less patients with PBC coming to the transplant clinic. This is because all the medications are out there. And again, ursodiol is, again, there's even data that even the late stages using ursodiol will prevent of you getting worse and actually needing a transplant. So we have a list of 180 patients in the transplant list. We only have 3 patients with PBC there. So again, this tells you that PBC, fortunately, is not a disease that actually gets sick really soon. The problem is when they get sick, there's no way to stop them. So I think, the kind of the lesson is it's such again, we were celebrating, I think February 20th, it's a weird disease. So it's very unusual to have PBC. I think going to PBC in a transplant center is also very unusual. And again, if it's an unusual disease, even all those patients getting listed for transplant, even worse. So not worse, but even lower numbers. So the answer is we're seeing less and less patients, but all the new medications are coming out there.
Certainly. And I think that there's been exciting sort of transplant level data in terms of reduction of risk of recurrent PSC post-transplant with URSO use.
Right.
That was good. I mean, interesting stuff from Global as well that just showed that if you end up being transplanted for PBC, if URSO is started right away, that's associated with a reduction in recurrence, which is great. Alrighty. This is a good question, I thought. What do you think about patient registries? How are they used? How do they help? Which ones do you recommend? What do you think?
I think both of us are part of the Globe PBC. So we started this registry, and the reason why is we need manpower and we need numbers to prove it's such a weird disease. So we need the numbers to prove that medications or things that we do work. And the only way to do that is to share these registries worldwide. Again, we're part of the Globe. There is the UK. I think, the registries is something, I think it's a no-brainer. Patients don't get any more blood work or anything else on their visit. So I think for us, it's just a consent. So we will disclose that if we do find some genetic associations, we will disclose that to patients. But there's no harm of joining an autoimmune registry. I think there is more benefit. We are doing better risk assessment. We're doing better treatments options for those patients based on this data that we can share worldwide.
Totally. I mean, none of this work from Global, none of the work, we have a Canadian-wide registry called CANAL in PBC and autoimmune hepatitis that we're trying to continue to expand, but none of the work about risk stratification or surrogate endpoints and any of that would be possible without patient registries, and patient level data. And so, and the limitation to the data that we have right now, I would say, is mostly that it relies just on biochemistries, but we know that regulatory agencies, the FDA, the EMA, Health Canada, they'll also start to look for patient-reported outcomes as it relates to drug approval and stuff like that. So, I mean, we're biased, of course, you and I particularly, but I think that for patients to engage in their care and engage in the research side of their care, in addition to the clinical side, only helps the field move forward. And that is ultimately what we work for, right? Improving outcomes for our patients, but we need to move forward with data. And I feel especially strongly about patient-reported outcomes. Like you mentioned, pruritus is a big deal, right? Especially with new agents, obeticholic acid, and even, I mean, patient level symptoms on their own. We treat the disease, but treating the symptoms are also equally important. And we don't have good measures for that, and drugs will only come, or good therapies will only come when you have good ways to measure them, but you need patients to help you with that. Good. Okay. Let me see what else we have here. Care pathways. For patients diagnosed young, say less than 50 years old, do you have an approach to establishing a different care pathway for this group? Do you monitor them differently? Do you treat them differently? visits more frequently? Anything that you do differently?
No, again, if this is the first year of therapy, I try to maybe see them 3, maybe at most 4 times that year, just to monitor make sure they don't have any side effects for the ursodiol. I think it's a good reassurance for them, making sure that the alkaline phosphatase is coming down. After that year, once we see that they're kind of responsive to ursodiol, I see them once every 6 months. I do a fiber scan every other year. I will not change any kind of clinical pathway based on their age. Again, I will see them more frequently if they're decompensated or they have cirrhosis. I mean, if they have cirrhosis, they're pretty well compensated. I see them twice a year with their ultrasounds and their screenings that they have to do, but I don't change my pathway based on their age.
Yeah, I think it's ultimately just the risk stratification up front, right? You think about their treatment response, their age at diagnosis, maybe fibrosis stage, and say that where are they falling into in this risk group? So if patients are diagnosed at younger than 30, is there a need for transplant higher?
So the data shows that they're less likely to respond. That doesn't mean that by default we'll need a liver transplant. So I think we will follow them closely. Again, we'll look at the alkaline phosphatase, we'll look at their biochemical markers, we'll look at their liver stiffness, and over time we'll decide. And again, the other part to this is the earlier we can treat, the earlier we can prevent decompensation. So not everyone who's diagnosed early, as I presented, will actually need a liver transplant. But I think, we will follow them closely and make sure they don't develop any signs of decompensation of liver disease, and we'll address that if it's needed.
Okay. This is sometimes interesting and causes controversy even in some of our meetings, but why do some people stop responding to URSO?
Well, I wish I know the answer to that question. I don't know. So the answer to that question is I don't know. I don't know if you have one, Aliya, or any and the Globe PBC have any answers to that, but I don't have the answer to that. No one knows.
Yeah, I mean, who knows? I personally clinically don't think that it happens that often. My instinct is that there's a proportion of patients who have stable liver tests and suddenly their enzymes rise. Sometimes that's in the setting of suboptimal adherence. Sometimes that's in the setting of a superimposed drug injury, or something else that's caused, maybe fatty liver or something else that's caused their liver tests to rise. But in general, URSO is a pretty darn good agent, right? It works. Once it works pretty well. So I agree. I don't know why there's a proportion of patients who do have biochemical changes over time despite URSO. I definitely make it a point to rule out other things.
Right.
But
I think this is, as you mentioned, we will do liver biopsies, we'll look at drug history. But if the answer is, how do we know what is causing the ursodiol not to work anymore? I don't think anyone has any idea why.
Yeah, it comes up at meetings all the time.
Yeah.
Okay, is there a way to measure hepatic encephalopathy?
Well, they're all subjective, unfortunately. We have the West Haven classification. We don't have an objective way to measure hepatic encephalopathy. There is some kind of driving kind of playstations that have been placed outside, the goggles where you look at different type of visions. But again, the answer to that is no. I think most of it's subjective, and assessment in clinic with kind of asterisks and physical examination findings.
And no ammonia levels?
Well, the ammonia level, I think, for hepatologists is absolutely no. I don't know if you encounter this, but most of the people will check ammonia. We have asked and recommend not to do that because basically it doesn't help to diagnose anything. So
yeah, agreed. So we mentioned this a little bit before, but is URSO post-transplant the standard of care?
Not until recently. I think Aldo published that in the Globe PBC and he showed that URSO post-transplant decreases the chances of recurrence of PBC and actually the need for another transplant. So we started since I think that publication came out last year or the year before. Mm-hmm. So we actually took it as standard of care. Any PBC patient, I know you guys publish it with strictures too. So anyone with a stricture or PBC actually goes in URSO, and then hopefully that will not require another transplant in the future.
Yeah, we just changed our practice too in our clinic when that paper came out from Globe. So it wasn't standard I would say, for the majority of clinics and the majority of patients. But I mean, recurrent PBC post-transplant is uncommon. It doesn't usually cause a huge problem, but there are a proportion of patients that do develop recurrent disease that's clinically meaningful. And if you can decrease that, I think that that's valuable.
Right.
So we've just changed that as well. We've gotten through a lot. We have 5 more minutes and then we can wrap up. So if there's any last minute burning questions, people can sort of write them into the chat groups. Let's see. Oh, does having children have any impact on disease?
No, absolutely not.
Agreed. I think we got through them all. We got through a good list of questions. So, I mean, I think we can both agree that management in PBC has become a little bit more complex. It takes a lot longer in the clinic now than it does. You have to sort of discuss risks and benefits of patients. What do you think, what do you foresee in the next sort of 3 to 5 years as the biggest changes in the PBC, in management of PBC?
I hope actually the stratification based on histology, I think that will be the kind of the holy grail for the hepatologist. If we can say, same as NASH, seladelpar or saroglitazar will actually stop, the fibrosis in this patient, I think that would be huge. I think what we need more treatment options for other problems that come with PBC that don't actually also often go along with the disease. And the two main, I think, is fatigue and pruritus. I think fatigue is a pretty significant complaint that we get in the clinics. We rule out everything else. We recommend exercise based on all the studies that published, but really don't have a medication. We don't have anything to offer to those patients. I think that's something that we really need to work on as physicians or kind of in the PBC world. I think pruritus is also a pretty debilitating problem. I think obeticholic acid actually can make it worse. LDFXRs can make it worse, but the data shows that it improves with all the PPAR, the new PPAR medication, but actually doesn't put it to rest. So they still have complaints about pruritus and they make life miserable. So we've had 2 plasmapheresis, and I can remember in the last 10 years, we had to list 2 patients because we had intractable itching and we had to list them for transplant, but we had nothing else to offer those patients. Mm-hmm. So I think that's something that we need to work on as clinicians. And finally, I think there are more other medications that we didn't mention. They're NOx inhibitors or the transporters in the intestine. So there are so many new medications coming out there. I think there will be so many new options and great options for patients that I hope we can really control the disease and prevent them from progressing to cirrhosis or needing a liver transplant.
Yeah, it's an exciting time to be part of the field for sure in the last 5 years or so. I think the older hepatologists have had, or gastroenterologists even, have struggled to keep up a little bit, but it's an exciting time for sure. And I think that one of the big benefits of these sort of forums is that patient engagement, you can see, is so important, whether that be through clinical trials or registries or just your data or participating in therapeutic interventions. The field doesn't move forward without patient engagement. And so that's what we're here for. We're here to treat patients, but also to answer questions as it relates to being involved in research and moving studies and projects forward. So I encourage you all who are listening to talk to your providers about options to be involved and engaged if you're interested, and if you're not, that's totally up to you. But I think a lot of the data that Dr. Bonder presented is just reflective of the progress that can be made when we work together as a team. Okay, I think we're ready to wrap up. With that, Gail, any final words?
Yes, absolutely. As always, I would like to thank you, Dr. Gulamhusein and Dr. Bonder, for spending your time with us and sharing your expertise. It's been a very informative evening. I'm sure we've all learned a lot. I know I have, yet again. And as I always say to all our presenters, and this is always from all PBC patients to you, we appreciate everything that you do to support your PBC patients as clinicians,